This is a case I thought would be of interest to colleagues and something, a learning experience that was certainly a learning experience for me. This is not the kind of case that a prosthodontist sees walk into his office every day, so I'm hoping it's going to be a valuable learning experience, and I wanted to show you some things that were of interest to it. So this is a patient of record who has been a long-time patient of mine, and he had a traumatic bicycle accident, and from the accident he had significant facial trauma. So by the time I saw the patient, he had already was brought to the hospital, brought to the emergency room, and underwent treatment for facial lacerations that were pretty severe. And he then went to a plastic surgeon, and the plastic surgeon had done most of his work. His mother brought him in to see me about 7 weeks after the accident. So as you can see, he has significant loss of tooth structure from 7 to 10. Teeth were highly mobile when I saw him, and no pain. Swelling minimal, except still swelling associated with the lacerations and work that the plastic surgeon had done. So one of the first observations was that the patient could not properly close his mouth, and no matter any kind of manipulation that I would try, this was the best that he could give me. And having been a patient of record, I was familiar that he had class 1 occlusion before the accident. So at first it wasn't readily apparent what has happened to this patient, and we referred the patient to an oral surgeon, and the oral surgeon did some workup, including scans, and from there it was determined that we had a fracture to the anterior maxilla, and that 8 and 9 were displaced palatally and incisally, including the bony housing of 8 and 9. So not simply the teeth being repositioned, but the bone as well. And now when you look at this picture, that makes sense, because you are seeing the gingival profile of 8 and 9 and the position of that gingival profile compared to, say, 6 and 11. And there's a series of 3 pictures that you can see the extent of the posterior open bite when the patient tries to close into his normal pattern, his habitual closure, and that's the same pattern that I would get if I tried to romance the mandible with the Dawson technique or other techniques to find centric relation. So this is his centric relation occlusion, and this is his maximum intercustation. And our x-rays showed basically no pulpal involvement at the time. Although number 8 and 9 did test non-vital, 7 and 10 tested vital, but patient has no discomfort at this time. So to bring the patient into something where he could smile and go to work, the patient is an attorney, and he would like to go back to work. So we did some transitional bonding, and as you can see, the transitional bonding gave him some improved cosmetics, but it has opened up the bite in the posterior even more. So now we really have number 8 and 9 in hyperocclusion. And just a close-up look of the transitional bonding and the degree of open bite in the posterior. So the patient was referred to an endodontist, and the endodontist proceeded with endodontic treatment for number 8 and 9. And from there, we went into a orthodontic device called an Inman Aligner. It was presented to the patient the option of traditional orthodontics, fixed ortho, and that was rejected by the patient due to his line of work. He preferred something that he could easily take in and out. So a removable concept was what he was interested in, and the Inman orthodontic aligner worked very well for that. So here you'll see how the Inman orthodontic aligner works. It's basically you have a outer bow and an inner bow, and the inner bow is going to push number 8 and 9 to the facial, and the outer bow shows you the position of our desired movement to get number 8 and 9 back into proper alignment. And the composite that you see on the lingual of number 8 and 9 are retention stops, which basically help keep the lingual bow in proper position so that it doesn't ride up on the teeth. And here's the progress that we see after approximately 6 weeks of movement. We can see significant movement of 8 and 9 to the facial. And after 8 weeks, we're basically close to our desired movement. And now we have a proper position of number 8 and 9. Now, you can see during this time we are also going through some rounds of occlusal equilibration, and primarily cupping out the lingual surfaces of 8 and 9 in order to get the bite into closure and to be able to develop some posterior contact. And of course, number 8 and 9 are still very mobile at this point because they've not only been pushed orthodontically, but they were also in traumatic occlusion. So here the position of 8 and 9 looks pretty good. There's a little bit of a flare to number 10, but you can see where we're starting to get some solid posterior contact. And a view looking up showing the incisal edge of number 8 and 9 looking quite thin in order to accommodate the new occlusion. So ideally would have been to position 8 and 9 with fixed ortho so that an orthodontist could perhaps move these teeth with an intrusive movement as well as a facial component. So if you remember the initial photograph of the degree of fracture, there was very little enamel support to work with on 7 and 10. As a matter of fact, you can still see in this photo, you can still see some of the bonding that I have added as basically core buildups on 7 and 10. And number 8 and number 9, any remaining enamel that was present had many fracture lines running horizontally through it. So I didn't really trust these teeth for doing a bonded type restoration or a more conservative type veneering type restoration. So this is our, just showing the limited amount of occlusal clearance that we could get for 8 and 9 with a little minor enameloplasty to the lower anteriors to get some space. Provisional crowns in place, and the provisionals were left in place for several weeks. I wanted to see how the patient would respond to the provisionals and how the occlusion would respond and the mobility patterns of the teeth. And there was significant improvement in the mobility during the provisional phase, and I was able to establish some solid posterior contact and some back to cuspid guidance. The final restorations delivered, and good integration with the final restorations. Mobility patterns became very good, and I was very pleased to see that. You know, when following an accident like this, when you're pushing teeth orthodontic on a segment of bone which has been fractured palatal, you know, my concern, of course, was that we would compromise the facial plate of bone on 8 and 9, and that the mobility patterns would possibly not improve to the point that I would like to see. However, on these teeth, things firmed up very well, and he became basically normal mobility patterns. So his smile restored, and a happy patient with this result. Our before and after. And this was a long treatment sequence. I was not in a hurry to complete this treatment for this patient. Several phases of treatment, including transitional bonding, temporization. I, delayed the next step on purpose for several weeks to really, I wanted to see how things would respond, and I wanted to see that things were stable before I went to final restorations. Thank you for your attention, and I hope this is of value to you. And I would certainly love to hear comments and feedback and suggestions, how you would approach this differently, and hopefully something that you've seen here that has been a learning experience and of some help for you to handle a case like this when it comes in your door. Like I said, this is not the kind of patient and not the kind of situation that I routinely treat and that I see. I don't think anybody sees these kind of patients routinely except for somebody who's probably in the sports dentistry field. So it is an interesting learning opportunity. Thank you for watching, and please email me or contact me with any comments or questions that you might have. I also want to thank other people that were involved to make the outcome of this case possible. Thank you very much.